We're live.
All right.
Hello. What's going on, man?
How you doing?
Doing well. I was showing Dr. Bendai here earlier, but this is my new like home office setup. So I have the treadmill on this. I got like the couch from my office over here. So we'll get this situated soon with it. um, cool. All right. So episode 3 that we're doing together today, we're talking about probably maybe not as much today, but used to be and still kind of is one of the more polarizing and misunderstood topics in health, and that is inflammation. So we're going to try to move past the simple idea that it's always bad and start to look at it as a signal, as like feedback, as data. And when we learn to read it, we can do stuff with it. Anything else before I kind of introduce the questions we're going to answer?
No, I think it's still something that I talk about on a daily basis with practice, and we hear it all the time. Everyone always wants to say inflammation, but it's like what actually is inflammation is it's so lost in that conversation, right? It's
Mm-hmm.
So I think what we're going to talk a little bit more about today as we get into it is that inflammation is like this umbrella term, right? There's different types, there's different versions, there's different flavors, right? There's acute versus chronic. You've got excessive, inflammatory, kind of aggressive. And then there's this low grade degenerative breaking down type inflammation, and they all kind of function differently. So I think that's going to be so helpful to actually get a better understanding of. So when you hear the term inflammation, you can actually categorize it and say, oh, okay, like this is how we're actually going to
Yeah.
talk about it. This is the purpose. What do you do with it?
Yeah. Okay, so today the 3 questions we're going to look at. What's the most misunderstood aspect of inflammation in the public narrative? I think we've already kind of given that away. In a clinical setting, how do we spot the difference between inflammation that heals versus inflammation that'll like stall recovery or lead to degeneration? And if inflammation is feedback, is data, what are some of the most reliable dials that we can adjust or that you can ask your doctor to look at to adjust to sort of redirect the loop without kind of shutting off the the data without shutting off that signal? Also, before we get going, Dr. Ben Rain wrote a book, Why Brains Need Friends. I am this far into it. I told him that I was going to give a review, and I don't like to review things until I've actually reviewed them, and life has been crazy, so I'm sorry, but I will I will post that soon. So far, it's fantastic. There was a cool thing that I hadn't heard about before, where rats who were given strokes, if they were isolated, they recovered horribly. Same stroke, if they were in with other mice, no other variables, just being socially connected to other mice, they recovered very well. And it's like, whoa, social connection can heal strokes faster. That's crazy. All right. So anyway, first question. What's the most misunderstood aspect of inflammation in the public narrative? It's kind of this battle between the bad guy to be silenced versus the necessary signal we must listen to. So inflammation is the bad guy and must be eliminated at all costs is kind of what we hear for the most part. Like we want to cold plunge our inflammation away. We want to diet our inflammation away. We want to supplement our inflammation away. We want to medicate, inject. We want to like just get rid of inflammation. And I think like looking at our notes here, I think I'm going to talk about one end of the spectrum and you're going to talk about the other end of the spectrum. But one of the sort of like logical quips I'll throw at people is like, if two things, like if inflammation is the root cause of everything and is the bad guy, how come NSAIDs and steroids haven't cured the world? Like, okay. And then the other thing is, like, let's look at it as a spectrum. Let's say, okay, so inflammation is bad. Yeah, to some degree, you don't want it to run away from you. But what if we have no inflammation? Well, now we're looking at something like AIDS. And now you can't mount a response to a common cold. You can't deal with a normal cut on the hand. Like, you need inflammation. So I'll let you pick it up from there. Yeah, those
That
are kind of my thoughts.
Yeah, and that's a good way to kind of like show the extremes to get a better lens on like, oh, okay, obviously that's not how we should look at it, right? And I kind of started jumping ahead and alluding to this, but it's like, when we look at inflammation, we have to understand what part of it we're talking about, right? Like, so we've got acute inflammation, which is like, you cut yourself or you sprain an ankle, right? It's hot, it's swollen, you get a lot of blood flow, it gets red. That's acute inflammation.
Mhm.
That's different than chronic inflammation, which is this low grade, simmering, smoldering fire that's slowly eating away at your body, right? Um, and it's different than this aggressive, huge inflammatory response that you mount from your immune system versus like a minor, small little roll going on, right? And the goal isn't just to, like you said, just shut it off, right? Steroidals or non-steroidal anti-inflammatories. Otherwise, we'd be good. We'd all be fine. You have to understand its role and when to do that. And one of the examples I really want to kind of help or use to help explain this is like think of COVID. Over the last few years, something that was in the media, it was in the medical circles. Everyone wanted to talk about it. It was something called the cytokine storm. Right, the
Mhm.
cytokine storm was this aggressive inflammatory response to the virus, and
Always inflammation.
exactly. It was inflammation on top of inflammation. It was unregulated acute inflammatory process that was really causing a lot of excessive damage while the body was trying to fight the infection, right? In that scenario, it's like, yeah, we need to slow that down. We need to calm that storm down, right? But on the other side of that, if you just completely shut it down with aggressive steroids or anti-inflammatories, and you just say, hey, we're just going to shut down the whole immune system. Now you've shut down your immune system's ability to also fight that infection, and that bioreplication just runs rampant, right?
Mhm.
So neither is good. It's
Yeah.
understanding that it's not just boom, bad guy, kill it, right? It's
Yeah.
you have to be able to modulate it and not terminate, right? And I think when we start chatting a little bit about this, when we start getting into some of the other stuff we talk about today, is that's the nuance. That's the whole idea, is that you can't just have this black and white image. We have to be nuanced with our approach, and we have to deal with inflammation as something that needs to come with us instead of just get rid of it and move forward.
Yeah, yeah. I remember early on, it was like scary. We were like, "What is this virus? Like steroids aren't touching it. Like, what's going on?" Um, okay, so we've kind of set up if inflammation isn't always the villain. Like sometimes it is, cytokine storm, but if it's not always the villain, how do we tell when it's helping us versus hurting us? So in things like tissue repair, which is kind of your regenerative kind of orthopedic world, and things like systemic health or brain health, what are the biomarkers or clinical signs that we look at to decide whether inflammation is kind of adaptive and helping recovery or pathological and not only kind of inhibiting performance, but like your overall health and quality of life? Um, and I think we've kind of belabored this, and we're going to keep belaboring it. But context is everything. So before, like, there are biomarkers we can run, and we're going to talk about those in literally a couple seconds, but there are biomarkers we can run, but context is everything. So one of the examples that I'll look at is like even just the timing of the labs. So if you have couch potato Joe who gets off the couch, goes to the lab core, gets his labs drawn, and he has high inflammatory markers, that is very different than the athlete who just had like interval training or strength and conditioning 24 hours before. Like, we might see elevated creatine kinase. It's like, does this guy have rhabdo? It's like, probably not. But like, like there's different contexts. And for most of us, unfortunately, we are really sedentary. We don't move much. Like 50% of Americans don't meet the standard exercise guidelines. So
Mhm.
most of us are going to fall on couch potato Joe's standpoint. And so we need to contextualize these inflammatory markers. So before I kind of go into more of that, like,
Yeah,
tell us.
totally. And so I'm going to stick to kind of what I'll focus on mostly in practice is kind of the orthopedic approach, right? Or the
Mhm.
orthopedic lens, right? So what I would describe is like the acute sprained ankle versus the chronic tendonitis, or what's really tendinosis. We want to call everything tendonitis, but 95% of like tendinopathies, tendon issues really are what we call tendinosis, which is chronic low grade degenerative inflammation, right? So when we look at an acute sprained ankle, you sprain your ankle, you get all this swelling and blood flow, you get this acute inflammatory response. Your body goes in there, immune system goes in there. We chew away all that old tissue. It's a lot. It's a lot of pain and dysfunction. But then your body says, okay, now let's heal it. That inflammation goes through a cascade up and down. So you go inflammation, then it calms down. Now you start the regenerative process. Now, we have the evidence that if we shut that acute inflammation down, as much as we don't like it, if we use NSAIDs there, that actually decreases that healing cascade that comes after the acute inflammatory response to get lower tissue quality later. So, in that case, treating that inflammation is actually bad. We got to use the context, like you said, and we have to use the context of what happened and what sort of inflammation there is to guide our decision making. It's like, no, we don't want to ice it and use anti-inflammatories. We want to move it and guide that healing process, right? Mhm. Now you compare that to something like chronic degenerative tendinosis, tennis elbow, golfer's elbow, right? Runner's knee, all these things where it's like, oh, these tendon just doesn't heal. And we want to give it anti-inflammatories, anti-inflammatories. I took ibuprofen, doesn't go away. Well, there's already exactly right. And so I see it all the time. People come in and like, I've had 2 cortisone shots and it comes back. It's like, well, that's because there isn't inflammation in an acute inflammatory way that you're trying to shut down. It's actually your body's not able to create enough of an inflammation response so you can get to the healing cascade. It's kind of like this hill that you have to get over. For those, science people that remember enzyme reactions in science class, right? You have to hit a threshold. And if unless you get over that threshold, the reaction doesn't go. It's kind of like that. So in chronic tendinosis, we use things like shockwave therapy. We use aggressive physical therapy techniques like cross fiber friction. We use platelet-rich plasma, PRP injections, stem cell injections. What are these doing? They are creating an acute inflammatory response, a controlled inflammatory response, so that we can guide that in from inflammation to healing and we can actually get a regeneration, right? Otherwise, we're stuck in this chronic low-grade inflammation that slowly breaks down tissue, feels better, but then it breaks down again, feels better, breaks down again. So those are two different scenarios. One where we have to modulate that inflammation, keep it moving, keep the blood flow moving and heal from the acute inflammatory sprained ankle, versus where we have to create inflammation to actually get healing because it's an acute controlled environment and an inflammatory process that precedes the healing cascade, right?
Mhm.
And so this is where like we have to be able to take the context of what to do, and we can't just say, oh, my knee's inflamed, my elbow's inflamed. It's like, what does that mean? What do we actually do with it?
Mhm. Yeah, I'm springboard off of that and bringing some labs into it where I think it'd be fun to circle back to you is what you're talking about. Especially when we're talking about like knees and elbows, you're talking about like a very local, like a very like I need this to be an inflammatory cascade that hits a threshold here. And one of the things that we'll see, like when you're looking through the research, or even if you're just looking at Dr. Google, when we're talking about inflammation, we're usually talking about chronic inflammation. And we're talking about chronic inflammation, we're usually not talking about something local. We're talking about systemic inflammation. So a term that you'll see in the literature every now and then that I like is meta inflammation. It sounds like this like spiritual meta, like kind of like overarching inflammation, but it's supposed to be shortened metabolic inflammation. Um, and like Dr. Bhandari said earlier, is like it's that smoldering kind of like in the background, like the embers at the bottom of a fire, or if you threw like a tissue or some kindling on it, it would still catch. And most of the time, that's going to come down to like your blood pressure, your blood sugar, your lipids. How physically active are you? Are you sleeping well? Like what's your alcohol intake? And so when we're looking at metabolic inflammation, that could also be one of the triggers that's impairing your regenerative healing. It could be we have a good a good body of evidence showing that the Western diet, the standard American diet, um, is this pro-inflammatory, metabolically inflammatory diet that dramatically slows and blunts your response to TBI recovery and rehab. Like you just do not respond as well if you're on a standard American diet because of the inflammatory impacts on insulin resistance, on blood lipids and blood sugar, all the fun stuff that I just talked about. So the relevant markers that I would want to look at is say you're not acutely inflamed, but like you're fatigued, you're kind of generally achy, or like energy's not what it should be, or recovery's not what it should be, and you're like, I'm worried I'm inflamed. It's like, well, what does that mean? And so we'll look at classic markers like your CRP, your C-reactive protein. We could look at ESR. Um, to be blunt, any doctor who's just throwing that at you generally doesn't know what they're doing because those are not very specific. They don't tell us much, and most of the time they're not going to be overtly elevated. Um, so what we want to look at then is we want to look at the metrics, even though it's not overtly inflammation, we want to look at the metrics of your blood sugar and insulin regulation. We want to look at the metrics of your blood lipids. So things like your triglycerides, your A1C, your fasting insulin, in blood lipids, not just total cholesterol, but like your ApoB and your lipoprotein little a. So we want to look at those things. But I wanted to tie into your clinical experience of like, how do patients recover who don't have those things in check when
Oh,
we're trying to work on something local?
definitely. I see big changes in people that are well regulated from a metabolic standpoint, don't have diabetes, exercise regularly, have adequate hormone levels, right, and are not super deficient in their testosterone, right. Um, they respond so much better. They respond quicker. I've found that when I started doing more hormone work and kind of regulating the metabolic health before doing my procedures, I probably cut my number of procedures down on average by like 50 or 60% on
Mhm.
how many procedures a patient would need to get to 100%, right? And so there is this definite improvement in healing because when you don't have high blood pressure, when you don't have blood sugar issues, you have better blood flow to your tissues, right? You're better able to communicate with your tissues, and there's less what I call static noise in the way of what your body's trying to get to the tissue. But if on the way there, you get stuck with having, tighter blood vessels or more inflammatory proteins and more things like when we talk about excessive fat tissue produces adipokines, right? These signalers, when people say, I'm going to go off on a side note here with inflammation, but it ties in, is that when people say, oh, my doctor told me I have to lose 20 pounds, my knees will feel better, right? It's like when you lose that 20 pounds, they're like, oh, my knees feel better. It's like, sure, you're less weight on your knees. But actually, one of the most important components was you reduced your metabolic load on those joints from a chemical standpoint, right?
Yeah.
You have less chemical signals coming from your excessive adipose tissue that break down cartilage, right? And so when you're trying to heal cartilage, for example, with PRP or stem cells, and you've got all these signals going to break it down, yeah, you're not going to heal as well, right? And even as far as like the people that get better sleep, right, are probably, I and clearly, like you just mentioned in the book that you're going to be reviewing, but socially interacting,
Yeah.
right,
Yeah.
are regulating their stress. I cannot tell you how much better people respond when they are not stressed and they're able to actually take the time to heal versus they're like, I got to do this procedure for my knees and then I'm back to work in 3 days and I got all this stuff to get done. And it's like, even if they're not physically active while they're doing that and they're just so stressed, they're like, man, my knees are so swollen. I just can't respond. I'm like, yeah, the stress is a metabolic stressor, right? It's
Yeah.
not just mental stress. It produces a chemical storm that also affects your whole body. So absolutely seeing the inflammation. Now that what we're talking about is this chronic low grade degenerative inflammation, these processes where your body's not able to go into the healing process, it's busy dealing with kind of the degenerative process. You don't respond to the acute inflammation well if you've got this, unregulated component over here.
Yeah. Um, two thoughts. One, if anyone's getting like lost in what we're talking about, I have two like deeper dive posts called Long Games. Welcome to the metabolic matrix, like the matrix of like how is this all connected? So there's part one, part two, where we talk about every lifestyle factor we've talked about. I give you details and links and references, and too long didn't read Eli 5 sections. So um I try to make it as accessible as I can. And then the other thing when we're talking about adipose, anytime I bring up adipose, someone yells at me for body shaming. One of the things that I want to point out is most of the time, or like not most of the time, most of the research shows that the most inflammatory fat is your visceral fat, the fat that you can't actually see. And that's driven up by blood sugar dysregulation, triglyceride, blood lipid. So you can be uh, otherwise outwardly like normal BMI,
Yeah.
fit looking, but you could have right now it's not NAFLD anymore, it's MAFLD, but the metabolic associated fatty liver disease. You could have uh, basically visceral fat around the organs, and that is probably one of the first steps we're finding, like years before diabetes hits, years before insulin regulation problems kind of occur. It's actually impairing your mitochondria's ability to just produce energy for those cells to work properly. And that is causing its own like radical oxygen inflammatory milieu, which is then kind of probably the first domino to fall before you go, you know what? I don't tolerate blood sugar as well. You know what? I'm not regulating lipids as well. So it's not fat that you can see usually that's harming you. All right, before we go on too many side tangents. So once we can kind of like read the labs, read the signs, we got the context, we've got the biomarkers, we've got some physical cues. The challenge for clinicians and patient becomes how do we redirect this inflammation without shutting it down completely? And we've kind of been teasing out this. So if inflammation is this critical feedback loop, what are some of the dials that we can adjust again without silencing it altogether, so that it's kind of a problem in the other direction.
Yeah. And so I'm going to come back to kind of something I was saying earlier. It's like inflammation is not something that we're trying to terminate, kill, and leave behind. It's something that we modulate and we have to bring it with us, right? And so when we talk about acute inflammation, someone has a sprained ankle and we're like, wait, we're in pain. We want to make sure that there's something in orthopedic or sports medicine, physical therapy world that we call secondary hypoxic injury. So when you have an injury to tissue, healthy tissue around it, just because of the excessive swelling and the oxidative damage that comes from injured tissue, just around there can leak into the healthy tissue and start damaging the cells in healthy tissue. And we want to try to limit that. That's called limiting secondary hypoxic injury. And traditionally, what we used to do was, NSAIDs, anti-inflammatories, ibuprofen. But we know that that's too strong. It shuts down the inflammation instead of modulating it, and we get poorer outcomes from tissue quality, that healing. Instead, can we use things that turn the dial down instead of turning off the entire thing? And that's where things like herbs and supplements come in, right? These are modulators, not suppressors, right? It's the idea of using like curcumin, turmeric, ginger, these what we call anti-inflammatory, supplements and herbs. These aren't necessarily anti-inflammatory. They are inflammation modulating. They turn the dial down on inflammation, not just in one single pathway like a steroid or an ibuprofen type thing, but instead they use like 10, 15 different pathways and turn them all down 5, 7, 10, 15, 20%. And so all of a sudden you have less of this acute inflammation while preserving the healing cascade, right? Mm-hmm. It's the same idea with omega 3s. And I mean, you can talk to this more better than most people, but having omega 3s on board or having things like, adequate levels in your blood and your brain when you have an injury, right? It can decrease the inflammatory and oxidative damage that comes from an injury, like, a head injury or concussion or something like that, when you have that there versus when you are kind of deficient in those same omega 3s or healthy fats, right? I'll use an example that we often use in autoimmune kind of conditions in the integrative functional naturopathic world. So naltrexone is a medication that's used for opioid addiction, right? It blocks the response of opioid medications on your opioid receptors. Essentially, we're simplifying here, but those are in 50, 100 milligram doses. It also works for alcohol addiction. Some people might have heard this. What we can do, and there's a lot of really good research on this from the LDN Research Trust, is a great group. But we take that naltrexone and we use low dose naltrexone, LDN, 4.5 milligrams, 6 milligram doses. What it does is it kind of just has this mild blanketing on your opioid receptors, your natural opioid receptors. And it tells your body, hey, you're not making your natural endorphins and enkephalins, your natural opioid, chemicals. What that does is it actually regulates your immune system to turn down the inflammation while keeping your immune system going. And what we find is it actually can help with autoimmune conditions. It can help with the low inflammation or the low immune response to things like in certain cancer therapies. No expert in that, but I've seen a lot of my colleagues use that. And so this is exactly what we're doing. And like I mentioned earlier, when I have patients come in with a torn rotator cuff, right? And they're like, hey, I have a partial tear. It's not surgical, but it still hurts and it's still damaged. We want to create local acute inflammation. We mentioned this earlier, PRP or stem cell injections, where we can actually create a local acute strong inflammation, but we're not spreading it all over the body. It's just this acute inflammatory response, and then it comes together, right? And so we use these kind of, you were using the term of like this precision dialing in, right?
Yeah.
We use these precision therapies to either calm severe acute inflammation and regulate, modulate it, bring it with us, or turn up the dial on a lack of an adequate inflammation so we can actually heal.
Yeah. Yeah. I'm gonna kind of echo a lot of what you said, but kind of my um take to that is like, how do we redirect the loop without silencing it altogether? Is like really understanding, again, like you already said, is like the context, the timing, like what's going on. Um, Generally speaking, and you can attest to this, and we've already said this, most of the time you don't want to intervene too fast. You know, in acute respiratory infections or something, like, of course, but for the most part, musculoskeletal injuries are the things that most people are going to be dealing with, kind of most often. You're not trying to move too fast because, again, you don't want to blunt that normal healing response. You want to prevent it from running away. When inflammation doesn't go away, that's when it becomes, the chronic, the meta inflammation. That's when it's a problem. But an example where not only would blunting inflammation be problematic, but blunting inflammation that's causing symptoms could be life threatening. I'm telling parents all the time, I know your kid has a headache after their concussion. Please do not give them a new medication. Do not give them NSAIDs, Tylenol. Don't give them an anti-inflammatory for the first 24 to 48 hours, specifically for headaches, because when you blunt symptoms, you risk missing kind of the peak of something where it would be problematic enough that you actually get the emergency care that might actually be required. You don't want to risk a life-threatening symptom after a mild traumatic brain injury, after a concussion, by throwing anti-inflammatories at it. Have I seen that happen? No. And it's one of those like conservative, be careful things. You don't, I can't imagine that a life threatening headache is going to be blunted by ibuprofen, and you don't want to risk it. uh, but going back to, so like, let's take concussion out further into post concussion, or let's take the people who have had post concussion, which is a lot of my patient population, where they're now concerned about chronic traumatic encephalopathy or a form of neurodegeneration, and we're coming right back to the most consistent, like iceberg bulldozer moving dials, and it's your diet, your sleep, your stress, your exercise. Is your blood pressure regulated? Is your blood sugar regulated? Are your blood lipids regulated? Are you sleeping regular hours, and are you waking up rested? Do you have sleep apnea? Like, we still need to look at that stuff. Going to kind of the concussion conversation without making it a concussion conversation is, when people are worried about CTE or chronic traumatic encephalopathy, the focus is on who played football and who hit their head. And it's like, that is a very important part of the equation. You don't want to repeatedly hit your head. I'm not an advocate for that. And I played 13 years of ice hockey. At my position, I statistically sustained 3 to 6,000 head impacts. Those are all in the past. I can't do shit about that now. So what can I do now? I can make sure that, like, look at the data on the football players who are diagnosed with CTE on postmortem autopsy. They also had diabetes. They also had hypertension. A good portion of them also had obesity and sleep apnea. A good portion of them also had alcohol abuse or misuse. What are the lifestyle factors that, independent of head impacts, will still push you towards neurodegeneration and this chronic metabolic inflammation? The same dials that we want to touch for everything else. So don't box over. Any anything else you want to add to that?
Actually, I was gonna tie it in a little bit with what you were just saying. It's I mentioned all these acute examples of these localized examples, but really, yes, when we zoom out consistently, those are the big needle movers, right? Is how do you affect the whole body at one time? right,
Mhm.
is you make sure you sleep, right? We know that the inflammation and both brain and full body inflammation changes with adequate sleep and waking at the right time and getting sunlight. Your nutrition is so huge, and we're seeing more and more data. Actually, even when I was doing some deep dive on research on, hey, how does diet affect pain? How do we actually do we what is the actual research we have on like
Yeah,
how does
yeah,
diet affect pain? What it said was what we found, the bottom line, if I were to sum it up in like one sentence or two sentences, was okay, the antioxidants that help offset these excessive inflammatory insults that we get from like excessive sun damage or excessive alcohol intake or whatever, right? It's the protective mechanisms, but really what they're doing is they're modulating the inflammatory cascades that are going on in the body. And so really is this what they describe as an anti-inflammatory diet, but it's not an
Mhm.
anti-inflammation diet. It's an inflammation modulating diet. And so nutrition, same thing. The best data we have is it modulates the inflammatory environment to help you better deal with it. But that's everywhere, from your brain down to your fingernails, down to your gut, in your muscles, everywhere, right? So
And it's most
those
likely secondary to blood sugar regulation,
exactly,
adequate macros and
exactly.
macros.
Exactly.
But
And those are the markers that we can track to say, are you doing enough with the diet or do we need to do more? Do we have to
mm,
add more of these big things like exercise, right? Do we have to add more of these things? Like social interaction. There's kind of emerging cool evidence to show that not only your inflammation, your brain, but like your blood sugars are going to be better regulated when you are socially engaged, right? So yeah, it's really important to look at the big picture approaches and not just get focused on these hyper acute small sections.
for sure. Okay. So let's wrap it up here because we're gonna chat again next month. We're gonna chat in November. But so core message, ultimate goal with like inflammation regulation. We don't want to inhibit, we want to modulate, we want to regulate. We want the body to have the right signals. We want it to have inflammation when it needs it. We want that to clear out when we don't need it, so that our body is more like more adaptive, recovery prone rather than like injury prone, degenerative prone. um, so we covered inflammation. In November, we're going to keep the conversation going. The title that AI helped me create was gut, joints, and heart. One inflammation, different languages. What we're going to dive into is talk about, we're going to kind of expand the conversation a little bit. We teased at it quite a bit here, but we're going to dive into why the inflammation that you feel in your knee or your elbow might actually also be tied to inflammation in the gut or inflammation systemically that might be related to cardiovascular disease down the line or neurodegeneration down the line. And so we're going to kind of expand and show you how when we're looking at these different systems, when we're looking at blood pressure, when we're looking at blood sugar, when we're looking at blood lipid, we're not just saying, "Hey, we're doing this to decrease your risk of heart attack." We're also now making it so that like you can recover from the gym session faster. Your knee's not gonna hurt as much. You're gonna sleep better. Like your quality of life is gonna be different
Mhm.
because we're taking away these slow smoldering embers that are not related to usually what you think about, which is again blood sugar, blood lipids, the boring shit that no one wants to talk about. Um, cool. Any other
Perfect.
thoughts?
I like it. Yeah, it's just we're gonna keep getting deeper and deeper on this conversation because there's a lot to talk about, and the more times you come around to it, you get to pick out and tease out little details that are sometimes clinically are like, oh yeah, I can think of that, and sometimes people, someone will hear it and be like, shit, maybe I should do something about this. That makes sense. Like that one
Yeah.
speaks to me, right?
In grad school, we had a spiral curriculum.
I was just about
No,
to use that phrase, but I didn't know if it would bring back trauma of being in med
yeah,
school
no,
of the spiral curriculum.
no, we're
So,
good.
all right. Well, that was great. Until next time, yeah?
Yeah, until next time. So next time, what was it called? Gut, joints, and heart. One inflammation, different languages. A love story. No, I'm just kidding. All right. See you later.
Take care.